Welcome. And as I said, thank you all for joining us today to discuss this very important and timely topic of the next generation and path forward on risk adjustment in Medicare's programs, particularly Medicare Advantage. I'm Mark McClellan. I'm the director of the Duke-Margolis Center for Health Policy, where one of our major areas of work is on supporting innovative care models that improve outcomes and avoid unnecessary costs, particularly for patients at high risk of poor outcomes. Risk adjustment has historically played a critical role in seeking to advance that goal in the Medicare Advantage program, for that matter, in all major CMS programs that are contributing to the Medicare goal of person-centered, longitudinal, coordinated care for everyone in the Medicare program. Risk adjustment aims to adjust base payments for plans in Medicare Advantage, providers in alternative payment models and traditional Medicare based on a patient's health conditions that are expected to increase risk and costs. The intention of these payments is to help ensure providers treating sicker, more complex patients have sustainable supports for doing so, or in other words, risk adjustment is meant to align the financial supports with the resources needed to attract and keep and deliver quality care to higher risk beneficiaries, whatever their needs might be. As a former administrator of the Centers for Medicare and Medicaid Services, I was involved in the early days of implementing the current diagnosis-based HCC risk adjustment system when the Medicare Advantage program was first beginning. It's played a critical role in supporting innovative care for complex patients, but the program and the approach is definitely showing its age as Medicare Advantage has grown and as electronic data systems have become more sophisticated. This system, based on claims, encourages more complete coding of diagnoses that are associated with higher costs under traditional fee-for-service Medicare, even if those diagnoses don't result in corresponding care management steps and increase patient spending. So CMS has another set of programs related to STARS that encourages quality reporting and encourages improved outcomes as well for patients with different kinds of conditions. But the data used there doesn't match up with the data used in the risk adjustment systems. And the fee-for-service claims data used from traditional Medicare to calculate payment adjustments for plans is becoming less and less representative of care in Medicare, and particularly care in Medicare Advantage or accountable care models. So for all of these reasons, there's been a lot of attention to ways to modernize and improve the functioning of risk adjustment in such a large program and growing program as Medicare Advantage. CMS recently proposed and finalized changes to its risk adjustment system that were intended to take some steps in the near term to address these challenges, essentially by reducing or eliminating the impact of many diagnoses that appear to be subject to considerable variations in coding across plans and that were unexpected to have an impact on beneficiary spending and outcomes. These reforms are expected to cause an incremental reduction in the spending growth in Medicare Advantage. At the same time, a number of critics from health plans and other sources have highlighted that at least some of the diagnoses involved, for example, those related to severity of diabetes or mild depression, might represent or do represent undertreated conditions in the Medicare population, particularly among lower income and minority beneficiaries who tend to have worse health status and face greater barriers to care. In its final policy decision, CMS determined to phase these changes in over 3 years and took many steps to examine the impact of the changes of these payments on beneficiaries, noting a number of evidentiary reasons why the impact might be limited. But as Center for Medicare Director Amina Seshamani has noted, with this phase-in in place, it is a good time to take a step back and think about ways to get to a better, modernized approach to risk adjustment, perhaps by building on these steps, perhaps by taking other ones. This matters not only in Medicare Advantage, but also in traditional Medicare, where 40% of beneficiaries and growing are in alternative payment models as well. So in addition to where we go from here on risk adjustment in the short term, it's also time to ask whether it's possible to transition to better approaches to risk adjustment. And is the juice worth the squeeze from more significant reforms that might lead to more uniformity across Medicare programs, that might do a better job using modernized electronic clinical data to improve accountability for this transition to value-based care that is the center of CMS strategies, and that is less prone to gaming and more prone to really getting at the goal of accountable payments for healthcare. We've got a very full agenda today to discuss these issues. Just a brief roadmap for our agenda today. For the first session, we're going to start with an overview of the current risk adjustment system, how it works, the challenges it presents to supporting effective transformation in our care system, and an overview of the recently finalized version of the CMS policy reforms and some of the discussion that led to that finalization. The second session will provide some perspectives on these changes and focus on short-term opportunities to improve risk adjustment in meaningful ways that both address short-term challenges like overpayments while still serving the purpose of supporting access and care innovation for more prevention-oriented early diagnosis and intervention for beneficiaries who most need it. The third session will focus on looking ahead beyond the short term. What's a vision for where risk adjustment systems in Medicare could go to support whole person accountable care in line with what we've learned over the past couple of decades and further progress in data infrastructure and oversight systems. We'll then have a few minutes towards the end of the meeting for audience questions. If you all have any questions or comments along the way, please do use the chat function at any time during today's webinar. I want to also acknowledge West Health for funding support for this and our related work on transforming Medicare and getting more value from payment reforms. Our discussion builds on previous work supported by West Health at Duke-Margolis to get to more accurate and sustainable risk adjustment methods. And our recent collaboration with CareJourney, reflected in our joint comment letter on the proposed Medicare Advantage risk adjustment reforms, reflects this as well. Our staff will be providing links to these documents in the chat. And again, we want to foster a dialogue here as we look forward, take a step back and look forward for where risk adjustment goes from here. Finally, I'd like to note that I'm an independent director on the boards of Johnson & Johnson, Alignment Healthcare, and Cigna. So thank you all for joining us today. And with that context setting, I'd like to turn to Frank McStay to kick off the next session.
Great. Thank you, Mark. And thank you all for joining us today, as well as thank you to all the panelists for, again, joining us for this really timely and important conversation on risk adjustment. If we can go ahead and go to the next slide. So I think it's really important to acknowledge exactly what Mark said up front, which is that risk adjustment has the ability to substantially alter the per beneficiary payments that plans receive. In the work that I linked in the chat from Duke-Margolis outlining some potential next steps for risk adjustment, there are a few of these examples. One of which is a gentleman who is living in a community with no coded health conditions, and HCC predicts that he have expenditures of approximately $3,000. The same man with coded diagnoses for diabetes with chronic complications, congestive heart failure, and heart attack would have expenditures predicted of almost $12,000. Now, that's not to say that those payments aren't going to really important care services delivering to those patients who have those chronic conditions. Rather, what this is giving voice to is the extreme importance of risk adjustment and altering those payments, those base payments that plans receive, and the potential distribution of those payments based on the variety of coded conditions. Now, this has tremendous implications for Medicare in a number of regards. One, it increases Medicare costs in ways that may not necessarily reflect patient value or value to the system. Again, that's not to say that those additional costs aren't going to the beneficiary in some way, but really that we just are increasing costs and we don't necessarily how that's reflected in those payments. This also leads to growth in the coding intensity factor, and there's also important implications for accuracy of coding. Again, we want to code accurately, but some of the incentives in place here might provide the incentive to substantially increase investments in coding overall, but not necessarily delivering high quality care or care management. Next slide, please. What this all amounts to is that the current system for risk adjustment still relies on a fee-for-service chassis that challenges transformation and whole person care, as Mark said. In particular, risk adjustment currently, the algorithm that supports it, doesn't really incorporate social risk factors or patient functional status into the algorithms. While there are some examples in ACO REACH and MCO contracts, there are a lot of questions and some concerns about the unintended consequences of these adjustments. And there's still a lot of questions about how to best incorporate these factors, which is something we'll get to in a later session. Additionally, risk adjustment still relies on those fee-for-service claims in traditional Medicare, where the data necessarily aren't representative or might otherwise be flawed. As Mark said, there's tremendous growth in Medicare Advantage recently, and over half of Medicare beneficiaries are in MA currently. That's problematic for a system that still uses fee-for-service claims to help adjust for the per beneficiary spending. Moreover, fee-for-service claims are still based on volume, not representative high-value care. And so the question becomes, do we really want to adjust for payments if we're not already taking into account in those payments the high-value care aspect that we desire? Finally, there's an underpinning issue with all of this in that there's a lot of diagnoses that go undercoded in traditional Medicare, especially among certain races and ethnicities. Next slide, please. So CMS recently proposed and finalized some changes that do try to improve upon the model in some ways, but there's a lot of questions still remaining. As Mark noted, the final notice phases in some of the phases in the proposed rule, including moving to ICD-10 and dropping or constraining certain diagnosis codes that we know are more frequently used and frequently coded in MA versus traditional Medicare. That includes diabetes, heart failure, and mild depression. During its final notice for Medicare Advantage in 2024, CMS acknowledged that there are implicit and explicit trade-offs between the different principles it's trying to work through, including Principle 1 and 2 about clinically meaningful and predictable expenditures, Principle 5, encouraging specific coding, and Principle 10, which is at the heart of what we're discussing today, which is trying to limit or some way mitigate discretionary coding, which again, may not be bringing actual value to the whole system. Finally, the proposed risk adjustment reforms shift payment away from beneficiaries that do actually have these diagnoses, which are especially prevalent in more low-income beneficiaries and marginalized communities. However, it's really important to note that we're not saying that these payments aren't going to those beneficiaries, rather that just the base payment has been adjusted and that there are concerns that maybe those payments need to be there for certain beneficiaries. With that kind of level set in mind, I'm going to turn it over to my colleague, Erica Everhart. Erica is an attorney and software engineer by training, but has deep expertise in value-based care overall, as well as alternative payment models, and is currently the head of thought leadership at Care Journey. So let's go to the next slide. And Erica, I'm going to turn it over to you.
All right, thank you. I'm happy to join everybody today. What we're looking at here was our assessment of the initial version 28 proposal and how it impacted different segments of the population. So what we did was we took 2019 Medicare Advantage encounters data, which was the most recently available data to us that wasn't impacted by COVID. And we sort of assumed that data was diagnoses for 2023. And then we used the published normalization factors and the version 24, which is the current HCC model, and the version 28 model. And we did some comparisons about what that same set of diagnoses would look like in 2024 under version 24 and under version 28. So you can see that we saw overall there would be a very slight decrease in risk scores for all beneficiaries. As you look towards a breakout between white beneficiaries and minority beneficiaries, you see a much steeper decrease in overall risk scores for minority beneficiaries. And then when we look at what we call dual eligible beneficiaries, which are those beneficiaries that are simultaneously eligible for Medicare and Medicaid, they have a 1.81% decrease in risk scores under version 28 for the same set of diagnoses. So duals look to be more impacted by this version 28. We do a lot of health equity research at Care Journey, and one of the ways we approach this research is by comparing a majority population to a minority population. So in the case of dual eligibles, they would be a minority population, and we can compare them to the majority of the non-dual population. And you can see in this yellow boxes here, we're looking at the difference in risk scores between duals and non-duals. And this, under version 24, the difference was that the dual eligible population had a 57.7% higher risk score. And under version 28, that difference drops to 54.5%. So you're seeing kind of the risk scores narrowing, which is a little bit worrisome because duals, we know, are sicker. And I just put in some dollar figures for what we call PMPY, per member per year, spend over on the fee-for-service side, since we do a lot of comparisons to fee-for-service. And you can see that in straight fee-for-service, so not MSSP, duals cost about 86% more. And so it's, the spend is higher than the risk score would indicate. So if I could have the next slide, please. We also tried to understand the impacts of version 28 by plan type. So what you're looking at here, each individual dot is an MA plan, and they are colored by the SNP type. So, and then so your x-axis is the percent difference in risk score, normalized risk score under version 24 and version 28. And then your y-axis is the percentage of duals in the plan. So as we see D-SNPs, the dual SNPs, they should be 100% dual. And you can see those are our orange dots. You can see there's a mix of plus and minus on risk scores for these plans, but you have a very long tail. So some of the plans who did see risk score decreases saw very significant risk score decreases. I-SNPs are the green, and they see mostly decreased risk scores. There's actually not very many of them on this chart. C-SNPs also see mostly decreased risk scores. Those are your blue dots. And then the non-SNP plans see mostly increased risk scores. And what this does not show you is the size of the plans, because some of the dots were very, very large and they obscured all the other little dots. But you can see it's a mixed bag of plus and minuses, but there's somewhat of a long tail, so that some of the plans who are seeing decreased risk scores are seeing substantially decreased risk scores. I'll take the next slide, please. You heard Frank talk about how there were differences or decreases in the codes that feed up to an HCC. So when we talk about a risk score, it's the sum of these relative factors. And a relative factor, it's meant to indicate the incremental cost to a beneficiary's care because they have that HCC, that condition code. And so with the version 28, we saw a realignment of ICD-10 codes to their hierarchical condition code. And that led to some notable changes when we look at things by disease group. So on the left, we're looking at depressive disorders. And about 50% of the ICD-10 codes that used to feed into a HCC, which would give it a relative factor such that it was additive to a risk score, about 50% of those codes no longer feed into an HCC code. The reason given is that beneficiaries who were diagnosed with those codes, we don't expect them to cost any more in the next year. So what you see here is under version 24, we had about 4 million beneficiaries that were diagnosed with a depressive disorder that fed into an HCC that gave them a relative factor. Under version 28, we see a 55% decrease in the count of beneficiaries that now carry that HCC that feeds into their risk score. But what you also see is these relative factors. These are, like I said, the incremental cost to a beneficiary's care because of that diagnosis. These are outputs from an algorithm. And so you can see that under version 24, anybody who carried that HCC had a relative factor of 0.309. And then when you move to version 28, now we have 2 HCCs that comprise depressive disorders. The majority of beneficiaries now have a relative factor of 0.299, and a small, not too small, but a percentage of the beneficiaries have a relative factor of 0.351, which would indicate a more substantial disease. So overall, you can sort of push this into dollars and cents by using these relative factors times the annual predicted cost for a beneficiary to see about 6.4 billion less in costs for treating depression. When we look at the diabetes group, it's slightly different. So one of the other changes that they made was to constrain values for certain diseases. So essentially they told the algorithm, spit out the values that you want, but make sure that anybody who's coded with diabetes, whether it's acute or chronic or without complications, they should all carry the same weight. So we think that diabetics, no matter the complications, because of their diabetes, should cost the same amount of money. And so when we're looking at, they didn't change any of the counts of ICD codes. So all of the codes still feed into an HCC, but we're weighting them differently. So you can see in the graph on the right, you have the same count of beneficiaries, but where we used to have different weights and the majority of the population carried a weight of 0.302, we now have everybody having the same weight, and that weight is 0.166. So you'll have the same count of beneficiaries carrying an HCC for diabetes, but the overall weight of those will decrease. If I can have the next slide. Oh, I think this is you, back to Frank.
Yeah. Thank you, Erica. And so what does this all mean at the end of the day? And there are a couple things that I think we can take away from the final rule. One, the need for standardized systematic approaches to analyses for risk adjustment and the proposed reforms, especially given the limited data or the flawed data we previously talked about, as well as the evolving market and kind of evaluation techniques. This interplays with everything from machine learning and AI to using more sophisticated regression model techniques, random fixed effects models that could potentially adjust or at least control for some of those or work through some of those potential discretionary coding practices. For its part, CMS did provide enhanced model and software specifics to help stakeholders understand what was happening in the proposed rule, which really aided in transparency. CMS also released additional analyses in its final notice, talking about these differential impacts on duals and how this interplays with the different principles, noting that no reform is going to be perfect, and there are going to be trade-offs between these different principles. The finalized reform does potentially shift away some payments from beneficiaries with these included diagnoses. And that doesn't mean to say that they're not getting payment, plans aren't getting payments for these beneficiaries, but there could be some unintended consequences of this, especially for beneficiaries in lower income populations and racial and ethnic minorities. Most important though, and we're all on the same page about this, I think, this just underscores the need to move away from fee-for-service and those data systems to more accountable population health models, including those in category 3 and category 4 payments. So that way we can support whole person accountable care. With that, I'm going to turn things back over to Dr. McClellan to get us started on our first panel. I'll remind everyone that you can use the chat function. I see a lot of different questions come in. We will address these towards the end of the webinar, but Mark, back to you.
Great. Thanks, Frank and Erica, for that those introductory comments on the proposed and finalized reforms in the Medicare Advantage risk adjustment system. I would add to Frank's comments at the end that with a lot of stakeholder interest, CMS took a number of steps in the final proposal to describe impact and consider some of the issues that Erica went through in her presentation. Would encourage people to take a look at that, maybe see it as a model for how impact analysis in this really important area of CMS payment reform can be done for the future. And I know CMS is interested in advancing the dialogue, the discussion, and the evidence to support its further payment reform steps related to risk adjustment. So with that, we're going to turn to discussing these recent reforms further, the motivation for them, their likely impact, how we can get better insights into achieving the goal here of accountable, longitudinal, coordinated care for all Medicare beneficiaries, particularly those in Medicare Advantage, and how CMS can build on these reforms in the near term and going forward to get to accurate payments, good support, and avoiding unnecessary costs. So I'm really pleased to introduce the panelists for our first session, who have spent a good deal of time thinking and writing about these issues while also being leaders in their own right and implementing steps to advance accountable person-centered care. Rick Gilfillan, a family practitioner, was CEO of Trinity Health System. Prior to that, he was deputy administrator of the Centers for Medicare and Medicaid Services and director of the Center for Medicare and Medicaid Innovation in the centers in the CMMI early days and getting that whole program off the ground. Rick has served in a variety of senior roles across the industry, including CEO of Geisinger Health Plan, Senior Vice President for National Contracting at Coventry, and Chief Medical Officer at Independence Blue Cross. Dr. Rahul Rajkumar is a physician and CEO of Accompany Health. Previously, Rahul was COO of Optum Care Solutions and also spent 4 years as a Chief Medical Officer of Blue Cross Blue Shield North Carolina, Blue Cross Blue Shield Care First, implementing many of its value-based care reform efforts, including in Medicare Advantage. Prior to that, Rahul also spent 4 years in government service as deputy director of the Center for Medicare and Medicaid Innovation. So thank you both for joining us today. You've got some great perspectives to bring to this set of issues. Rahul, if you don't mind, maybe I'll start with you. And we've talked about the potential impact of this regulation. So understanding the impact of reforms and risk adjustment on Medicare Advantage plans is important. It's a $300 billion plus program. As Frank said, these payments move a lot. These risk adjustment features move a lot of payments around. Maybe you could start off with some of your perspectives on how plans might respond to these reforms and what the implications for beneficiaries might be.
Yeah, Mark, so I appreciate your having me. Before I answer your question, I just want to say, and when I prepared for this, I talked to two really smart people, one of my colleagues, Scott Heiser, and former colleague, Sean Kavanaugh, and was just exchanging ideas with them. So anything that remotely intelligent that I say, I would credit them with, and anything unintelligible I say is solely my own.
We'll blame you, yeah.
Yeah, no, please. I guess the way I would describe where the final rule landed is that it's a fairly modest set of reforms that makes a lot of sense to me, and I actually think the ways in which plans will respond will be fairly muted. There's a huge technical effort to transition from version 24 to 28. That is really not that interesting to talk about, but we're doing it as a company, so we are a risk-bearing provider. There's really nothing that juicy or interesting in that. I think that prior to the final, there was some concern that we would see deterioration in benefits on the plan side. I really don't think that will be the case in the short term because the year one impacts are so modest. If I take a step back, I just philosophically, Mark, that I think that a lot of the discussion around this is missing some of the underlying reasons why this is incredibly important to have a system of risk adjustment. And you mentioned this in your lead comments. It is in recent memory in the United States that we had a sort of non-functional Medicare Advantage system that was really for healthy and wealthy beneficiaries. And it really wasn't until the reforms that you implemented that we saw more widespread uptake of MA and plans stopping cherry picking and lemon dropping. That experience has been repeated not just in the United States, but in other countries. In Germany has sickness funds, and their observation in the 2000s and the 90s and 2000s was that young and healthy patients were willing to change sickness funds that had lower contribution rates. And so they implemented a system of risk adjustment that's very similar to HCC. I think that the fact that many plans are profitable in this space and becoming more profitable is a marker or suggestive that we should pay more attention to this. But to me, that's sort of a side issue. The real issue is that we want to get the policy right and make sure that risk adjustment is done with precision and accuracy. Yeah, I'll pause there. I have a couple of thoughts on the way the rule came out, but I'll go back to you.
Great. Well, we'll come back to those further thoughts, and I appreciate the comments. Would add too that CMS in their analysis noted that accounting for other factors, they're trying to, as you know, CMS is trying to do more to account for social risk factors and structural barriers to access to care that might lead to undercounts and spending for unmet needs. So, for example, dual status counts a lot in this and as we look ahead for further Medicare changes. But Rick, let me go to you. In your comment letter on the proposed changes, you were encouraging, along with Don Berwick and others, that CMS go ahead and finalize the regulations as proposed. You've also talked about some other steps to tamp down on the increasing risk scores that have been seen in recent years that have a lot of consequences for Medicare spending. So where do you come out on where we are now and where we go from here?
Well, again, thanks for having me, Mark. Appreciate you all doing this and all the work that you all are doing on this and other issues related to Medicare. So a couple of thoughts. I just to go back to some of the comments that Erica had. I think it's important to kind of tell the other side of the story, if you will, here. And we were fortunate in that United Health Optum published a study in December that showed the actual degree to which this is occurring. This increased risk scores was occurring, and particularly in the context of practices that had percentage of premium or full risk contracts with the provider. And I think, to Rahul's point, some other issues are important here, like a projected $600 billion in overpayment at a time when we can not afford many other social initiatives. That's a big deal in my mind. Like the fact that we're seeing a rush of Medicare eligible folks into MA because it's so heavily subsidized. And we've published lots of documents and happy to provide them, but to show that virtually all of the rebates, all of the better benefits that are provided through Medicare Advantage are the results of various subsidies. So we've created this subsidized, privatized alternative to Medicare, and we're pushing everyone into that. And interestingly, at the same time, we've created what we hoped would be an alternative to that, namely the ACO program. And we've taken virtually the exact opposite position in every dimension of ACOs when you compare them to MA. That is, we've made it more difficult. We've made it less profitable. We've made it less attractive for both providers and patients. So I think that the policy issue is to hit a pause and say, why are we so aggressively subsidizing the march of folks into Medicare Advantage at a time when it costs more, and we can debate better quality, lesser quality? To Erica's points about the redistribution, I would point out that in the United Healthcare study, they went to great pains to show that these were matched populations. My population sicker wasn't an issue. They showed clearly a matching of the population, and they even showed that the traditional Medicare population, when they compared them to their capitated groups, actually were sicker in several dimensions: more cancer, more transplants, and on anything that wasn't discretionary encoding, they were roughly the same. But on the discretionary items, particularly the ones that were mentioned by Erica, they had 3.5 times, 350% more people with psychiatric diagnoses, almost 600% more patients with substance abuse, about 1.5 times as many people with diabetes, but a big shift towards the complicated side of the diabetes HCCs, about almost 4 times as many people with vascular disease. So there's a massive problem going on here that was, and I don't believe this is fraud. I believe this is gray areas, and that traditional Medicare is significantly undercoded. But Medicare, the dollars associated with traditional Medicare are real. They are what it costs to take care of people with the conditions that as they're distributed in traditional Medicare. So the right coding for any population to approximate what Medicare pays is the same coding as traditional Medicare. Anything above that results in overpayments. So I think that I would say is number one. Overall, we demonstrated that their risk score went up almost 50%, about 45%, as a result of the coding that was done by the groups that were incented through the percentage of premium contracts. Their premium opportunity went up about 35%. And that on an average would be an increase overall of about $300 per member per month, $350 per member per month. And to Medicare, that's an added cost for every million members of about $3 to $4 billion. So this is not a minor problem. This is like an entire industry that is being subsidized and using some of that subsidy to attract more patients through better benefits, lower premiums, right? And that's the policy issue. From what we can see, and I haven't done a detailed analysis of this yet, and clearly the Optum group was on the extreme. They're not the highest, but they're on the extreme. United Health tends to be the highest, about 1.3 at a corporate level of risk score. Clearly, as I think Erica showed, the folks who were at the far end of the tail of risk coding were impacted more. How this will impact percentage of premium contracts that we're talking about, whether or not, it will have a major impact, it's hard to say. My guess is that it probably got more than 50% of those increased premium dollars will probably be impacted for those groups, but we have not completed an analysis at this point. And as Rahul points out, there's a couple more years to go before we see the full impact. What will happen as a result of the introduction of new codes remains to be seen. But finally, I would say in several of our writings, we've encouraged CMS to move to a different system, an entirely different system of coding, of risk adjusting that would be based more on patient surveys to find out what the distribution of illnesses really is, and also utilize, or at least investigate the potential for using various social determinants of health indices to see whether or not they are useful in projecting costs.
All right, Rick, that is a lot to get on the table. Thank you for covering it all so concisely, and I appreciate the passion you have behind this issue, given the implications, as you said, not only for Medicare spending, but for care and for uptake of Medicare Advantage versus maybe reformed programs in traditional Medicare like ACOs. Rahul, you have also written about this topic, including percentage of premiums are similar, and if I'm going to paraphrase a chart, and I really encourage everyone who cares about this issue to look at some of Rahul's past writings in health affairs as well as Rick's. But you have a chart, if I remember right, in that paper that shows sort of this what Rick called the gray area getting bigger. On the one hand, care coordination in Medicare Advantage plans and similar, potentially leading to lower costs and maybe better outcomes. But on the other hand, this coding increase going on at the same time. Is that gray area something you just have to live with? Is there a way to get more of the care reforms and not have quite so much of the increase in coding? Rick raised some issues about risk adjustment reform that we want to get to, but I'd like to get your take on this this overall way of framing the challenge and how to approach the solution too.
Yeah. Well, first of all, tremendous honor to be on any call with Rick, and I've learned so much from him over the years. But that said, Rick, I really think that the way you describe, I don't fully agree. I think that I think I disagree, but we'll get to the same place. I think it's maybe a little bit overheated the way that you described it. And so let me tell you what I mean by that. I don't actually think that there is any national policy or CMS memo that says that our national goal is to drive people into MA. I don't think that there is
Agreed.
a stated policy on the Democratic side or on the Republican side. I think it is a byproduct of some technical deficiencies in the way that we're going about this. And so the current policy that CMS just finalized did some things that I think are the right direction for the current system that we have. So it's optimizing the imperfect system we have. And so number one, the recent rule isolates HCCs that were being captured and not treated. So, that's important. So we want things to be connected to treatment, forces plans and providers to capture codes that have higher specificity. Agree with that. And the third is sort of unstated, but sort of in the background of this, is trying to get to eventual parity or level the playing field between fee-for-service and MA. I mean, those are the policy principles. I think that you would agree with those things. And I also agree in the longer term, what is the real structural problem here is a principal agent problem, and it's at two levels. It's between CMS and the plans, where CMS wants accurate snapshot of the level of risk of the population, but the plans have an incentive to overstate it or to hunt for it, as you said in one of your papers. And then the plans pass that on to the providers, right? And if they didn't, they would have a principal agent problem in the other direction, where they're on the hook, but the entities, the agents that actually do the work of capturing diagnosis codes are not incented to report it accurately. And so they've tried to correct for that, like through these percent of premium contracts. I think that the way to solve this is exactly what you just said, which is to disintermediate the plans and the providers and get to some long-term solution where your CMS is surveying beneficiaries directly. And I think that would largely solve the problem. I think it would obviate the need for some of the other things you're describing. I think a percent of premium contract with a risk contract with a provider you wouldn't have the same issue if you were surveying beneficiaries directly to assess their risk score. I guess the last thing I'd say, Rick, there was a statement that you made that the cost of care, it actually is what it is in fee for service. I forgot exactly how you put it.
Mhm.
That's sort of true, although you and I also know that there are some areas of care delivery where we'd like to see a greater intensity of effort. Take primary care, for example. Like the average Medicare fee-for-service beneficiary receives about, I don't know, somewhere between $30 to $50 PM primary care.
Mhm.
And one of the effects of MA is that it has shined a spotlight on primary care. So many of the new entrants that you've seen, including Optum, but many of the other for-profits, yes, they do a good job on coding, maybe too good a job, and focus on it a lot. But that is how you finance $100 or $200 or $300 PM primary care for people that need it. And so, the fee for service system vastly underpays for certain types of care that I think need to exist in the world. And like the only way you can get there is by paying for it in a way that you're adjusting for the underlying need or risk of the population. So I think in the end, I hope that we largely agree. I mean, I think that there is a better way of doing this, and that I have no doubt that will be the long-term policy direction. And I look forward to the day that we get there. I'll leave it at that.
I do want to come back to, this will lead into our next panel too. How do we get to that day sooner, if that is an area of agreement? But somehow I think that Rick has some responses he'd like to add at this point. Rick, did we lose you?
Oop, I think we lost
Okay.
it.
That would be sad.
Okay,
That would be
I
the
know we
best,
have
that
some
would be the best part of the
responses.
panel, Mark. We can't.
I know, I don't think you took it personally, Rahul, but as we get Rick back, let me ask a follow-up for you around data. So I get the point about getting data directly from beneficiaries. Actually, CMS does that now with CAP surveys, or CMS doesn't do it directly, but a third party does. And I can see how that would work for things like functional status, but I wonder about just how reliable that's going to be for things like disease severity or particular types of clinical conditions that may be a little bit more challenging for people to recognize and even want to be surveyed about, but that are really important parts of the clinical care management plans that organizations, including organizations like yours, are implementing. Can we really get all the data that's needed from beneficiaries and not the clinical care systems that are so important for, I mean, those clinical care systems depend on a lot of other things. Other beneficiary perspectives are important, but they depend on a lot of other things in terms of clinical information too.
Yeah, I don't
Mark,
disagree.
sorry about that. Can you
Yeah,
see me?
we're going to be right back to you. No worries.
All right,
Thanks
that's
for
fine.
thanks
Okay.
for being with us.
No, I think you're right, Mark. I don't know the answer to that. So ultimately, the purpose of risk adjustment is to predict cost. So that it's very easy to say, yes, we should survey beneficiaries, but I'm not immersed in the science personally, but that science has to be developed to use survey data to predict cost. And there are many people working on it. I know that it's happening. Um, what you describe of sort of capturing diagnoses is part of clinical medicine. Like any good provider, any good doctor or other type of provider does that in the course of a normal history, and that should continue. I'm not sure it's necessary to have a cost prediction model. Like I don't know the answer to that question. But if there is a way to do any type of survey that disintermediates plan and provider and accurately predict cost, maybe to a degree that's more precise than the current HCC model, that would be desirable.
Yeah, it's certainly something that there's certainly important dimensions of predictable costs. I mean, we don't have to predict all costs. It's really just the ones that could influence the expected spending for a beneficiary and might therefore make plans feel like it's less sustainable to keep that person in their plan if there isn't an adjustment in payment accordingly. There certainly are some things in surveys that are probably not captured by clinical diagnoses, like functional status and maybe social barriers. To Rick's comment earlier, social barriers to access to care. So I appreciate Rick's perspective on this, but Rick, glad you didn't drop because you found Rahul's comments so offensive. But if you did have any follow up on what you heard from Rahul, and then we're going to try to talk about a little bit more about where we go from here.
Sure. Well, no, I didn't find them offensive, and I admire Rahul and all the work he's done, and he was a great partner. We were great partners together, I think, at CMS. So I have a total respect for everything he does. I think, and by the way, I thought his paper was great also, and I would agree that everybody should take a look at it because it tells the story, and it was before our articles. I would say it's right. It's true. Percentage of premium contracts are not the problem. The problem is the ability to set the premium. And I think the same problem is true with use of clinical data, Mark. If we can get providers out of being part of the game, if you will, then you're absolutely right. It makes sense to use the clinical data. The problem is that the data is all corrupted at this point. It's totally engaged in the system of creating more diagnoses, right? And so as long as we have the HCC system operating as it is, and we have percentage of premium contracts or payment for gap closures, right? One of the great euphemisms, or gap closure percentage as a metric for health systems, which I've seen used at the highest level of health system executive scorecards now. As long as we have that stuff going on, we can't use either the data, I think, or we can't use the natural sources that make sense. So I think Rahul is absolutely right. We should eliminate the HCC system and go to something else and rely on real smart people like you and folks at all those big university and other think tanks to do the analysis and tell us what can we get from beneficiary surveys, what can we get from SDOH indices, what can we get from using the drug information, which may or may not be okay, right, and uncorruptible. I'm not sure, but I think that's what needs to be done. I think CMS took a great step forward, and I'm really supportive of that. But I think the big story is we need to eliminate the whole system, and we need to eliminate. And if we can't do that, then we need to take steps to eliminate percentage of premium contracts and these other incentive systems that basically engage the provider side in the coding problem. I think the better solution is to come up with a different risk adjusting system, and I don't think it's that hard. And the one other thing I'd say is, it is interesting. I was in the MA business. I helped manage or start 5 different MA plans, going back to the early 90s. Quite honestly, the whole cherry picking, lemon dropping thing was not that big a deal. We used to use gym memberships to attract people who are healthy, but there was not all that much consciousness of it, to tell you the truth, at the time. And we've gone way over in saying that we need a system like this to address what was relatively minor problem, frankly, at the time.
Yeah, I think we could talk about that for a while.
Yeah, I don't want to go into it.
There
Yeah.
before those risk adjustment factors were included versus after, including for drug costs, which are also predictable.
Yeah.
I think it does make a significant difference. But I think this gets back to the core problem is that I think both of you are saying that the data that we're relying on for risk adjustment and for that matter for determining if these risk adjustment changes have consequences are just not reliable because they depend so much on financial incentives for reporting. So it's the question of how do we get away from that while still having reliable, well enough functioning systems. There's an important set of further research questions here that hopefully can have some near-term progress for further reform to guide further reforms in risk adjustment. And I want to come back to that a little bit further and also talk about, as you said, there's a different model in place in the accountable direct contracting programs in traditional Medicare that takes the opposite view on some of these issues, like percentage of premium contract implications for payment. But before I get to that, CMS is in the process, as part of their quality strategy, of moving to more clinically based data for many of their performance measures that also influence payments to plans. It's sort of the flip side of risk adjustment. The risk adjustment is kind of the denominator, patients that have that truly have a health risk that you'd like to support care to improve. The numerator is, well, what's going on with those programs? And there, CMS does rely some on surveys of patients, and increasingly so on things like functional status and the like. That's part of their strategy. But that strategy is also moving for clinical measures that may be hard to measure reliably directly from patients to relying on clinical data there too. So I'm just trying to think of whether you all have further ideas on how these overall systems can be unified, because it does have implications back at the plans, as you emphasize. There's some contracts that are based on clinical risk as measured in the so-called risk adjustment factor, or RAF score. That's this claims encounter-based data that goes into risk adjustment. But CMS is also trying to increase the amount of payment that depends on accountability for actual clinical results using clinical data. So are there ways to bring those together and maybe get more investment in systems that do both, rely on better surveys of patients, which providers need to know to improve care and plans need to know to improve care, and better clinical measures? And
One
follow this up in the next panel too, but I appreciate your thoughts.
Yeah, one quick thought there is, the whole issue of patient-reported outcome measures. And are we giving up on that? Is that, have we just decided that is not going to be useful? I'm not sure, but it's the logical analog to doing surveys for the risk adjusting side, it seems to me, right? And I wonder about, and I don't know whether it's too much to engage patients in that much, reporting kinds of activities. Quite honestly, I'm not sure, but I think that's one analog. I do think, I always thought that the beauty of electronic medical records was going to be that we could, get real detailed information from the point of care that would help us on both the quality and cost management side. So I would again say our goal should be to have a non-corrupted infrastructure. And I think the HCC system may be fundamentally in contradiction to that. And that may be the biggest reason for us to say, because the screwed up risk scores ends up making it really hard to do quality comparisons, right? And so when you come right down to it, so I think there's a fundamental contradiction here. And I think we have to free up providers and their infrastructure from being corrupted by trying to maximize revenue, to be honest. And by the way, I don't think there's any bad people in healthcare. I don't think anyone's planning to push everybody into MA. It's just a natural result of decisions you made, I made, Rahul made, other people made. I think we need to fix them.
Yeah, financial incentives definitely matter. Rahul, agree with that? Further thoughts?
Well, just a small addendum to what Rick said. I actually didn't make any decisions. I worked for Rick, so the decisions were all his.
Blame Rick, right?
Um, I really don't disagree with Rick very much on this. I would say that I would maybe use different words to describe some of this because I see these more as technical issues that have to be solved. Like I'm not sure I would use the word corrupted to describe the data that we have from MA plans. Uh, like there are actually two things going on here. MA plans and providers in MA risk contracts have an incentive to hunt, as Rick says, for diagnoses to code accurately. That incentive largely doesn't exist in straight fee for service. And so it's very hard. I agree with the point that you can't make an accurate comparison between the two, but one is potentially overcoded, one is potentially equally undercoded. And so that is a problem, but I maybe describe it with a different framing.
Yeah. And I know we're about out of time, and Rick Gilfillan actually had another engagement that he had to get to. So I'm going to give one more comment to, Rick, if you're still there. I did want to get back to this question quickly of where to go in terms, okay, we get the point about better data, reliable data, and incentives to support that. We're going to pick that up in the next panel. But for right now, there's a different system in place in Medicare, ACO programs, Medicare Shared Savings, ACO Reach. How do you see what's the optimal alignment between these two? Both get to better data. Any other learnings from either side that could be better integrated for, as Rahul was saying, similar incentives in both programs?
I think, yeah, I mean, the ACO Reach risk adjusting system is a killer, and I think it's probably going to end up, limiting that program significantly because it's so tight. And I mean, that's ironically me saying that, but I think that it creates a sharks and minnows phenomena that makes it very hard for non-aggressive coders to be successful. I think we need to think about a level playing field. And I don't know, I would like to think that they could do something through CMMI, a combination of CMMI and shared savings program that would create many more points, common points between MA and the ACO world. And I'd like to see them get on the same level, a level playing field, and let's see what works better, truly contracting directly with providers or going through insurance companies. I think that's a fair question, but right now it's not even close to being a competition. It's just it's lopsided. And again, it was not done purposefully. It is the nature of the way policy works in America, that the status quo tends to steamroll. It just keeps growing and growing and growing. And that's what we've got, right? It's just the natural evolution of creating a constituency that has an interest in maintaining a status quo and making it even better, right? So, we see that in every dimension. So.
Yeah, Rick, thanks so much for joining us today. I know you've got a tight schedule and really appreciate your perspective. I just add, when we did implement the HCC system with these claims-based code reportings, I had no expectation that we'd still be talking about this system a couple of decades later, given all the promise for electronic data and getting information directly from the patients, the beneficiaries affected. Rahul, I turn to you for any final comments on how we move forward from here. Anything you'd like to add?
No, I mean, the last thought, I agree with Rick about leveling the playing field. And actually, this was my phone a friend from Scott, that a really important part of that is also leveling the benefit design on both sides. So and that would require Congress. But I feel like we have somewhat ignored or obliterated that consideration in this conversation, that if you're part of the reason that beneficiaries choose Medicare Advantage is they get stuff that, and I think it's debatable whether that stuff is socially useful or important to healthcare or whatever, but it is stuff that they value enough to choose a Medicare Advantage plan. And that stuff largely doesn't exist in Medicare fee-for-service. And so that's another important dimension to this if we were going to level the playing field.
Yeah, and just to be clear on that, I would agree totally. I wonder if there's some potential for doing that on a demo, on a, a model basis through the Innovation Center, but I agree that absolutely is an essential part of it. And by the way, there are opportunities to explore on with Congress some of these changes. And the good news there is there's actually a scorable opportunity that might attract bipartisan interest.
Well, that on that optimistic note, I want to thank you both for this panel. Clearly, the risk adjustment issues are hugely important in their own right, both in Medicare Advantage and in traditional Medicare with its shift towards more accountable care models. But there also are other interactions as well. Now, we're not going to get to all of those today, but I do want to turn now to follow up on some of the short-term issues and challenges that that our last panel raised, including the point that, just to paraphrase Rick, that our current HCC infrastructure may be fundamentally at odds with the goal of a non-corruptible, clinically and patient-focused, accurate system for serving as a basis for risk adjustment and maybe reinforcing or aligning with policy goals and trends in quality measurement and quality improvement and payment as well. To follow up on some of these issues, I'm really glad to be joined by our second panel today. So Erica Everhart, Head of Thought Leadership at Care Journey, someone who you've been introduced to already. And I'm also glad that we're joined by Dana Safran, who's President and CEO of the National Quality Forum, previously a senior executive at Blue Cross Blue Shield of Massachusetts, where she was a lead architect of the Blue Cross Alternative Quality Contract back in the early days of implementing outcome-oriented accountable payment systems for total cost of care with providers. And I know Dana also has a tremendous amount of experience through all of this with quality measurement, patient-reported outcome measurement, and understanding how different factors can contribute to predictable differences in healthcare spending and ways to measure those effectively. So Dana, let me start with you. One of the issues that came up in the last panel was the notion that some important dimensions of patient risk, predictable risk, aren't captured well with diagnoses alone, whether based on claims data or maybe more accurate clinical systems. That includes social risk factors. It includes functional status, as was discussed in the last panel, frailty. Now, these are issues that the NQF has been thinking about a lot, including a recent report on how to incorporate these kinds of factors into risk adjustment. So based on all that experience, can you talk a bit further about where we might go from here, starting with those factors, which do seem like important information to get from patients? And then I want to build out this discussion around more accurate sources of clinical information, both for measuring risk and for understanding and supporting accountability for performance.
Yeah, absolutely. Thank you so much, Mark, and thanks for the opportunity to be part of this really important discussion today. So as you say, NQF did just publish in December of 2022 a report on the issue of social and functional risk adjustment. It was really the culmination of 8 years of work that NQF has led on this topic. In part, that duration, because the topic, especially the social aspect of risk adjustment, has been one that has been and remains controversial. I don't think it's really been underscored here today why it's been controversial. So I'll just spell that out for a moment, which is there are really two perspectives: a perspective that you must adjust for social risk. If you're not adjusting for it, it's unfair to providers who serve disproportionately populations that have social risk factors and could cause them to select against those populations and thereby harm those populations. Others who believe it's unfair to patients to adjust because it will obscure differences in quality outcomes that are being achieved for those populations. So this panel, which included measure developers and methodologists, purchasers and payers, and clinicians and patients and federal liaisons, and also included focus groups prioritizing inclusion of those historically underserved, really grappled with these issues. And I think offered a few breakthroughs. There's no easy answers here, no matter what. But one of the things that the panel recommended is that risk adjustment has to begin with a conceptual model of what are the variables that should be adjusted for and why. And that may sound obvious, but it had not really previously been stated and has very important implications, I think, for measured developers and for us in the field. They then outlined a minimum set of factors that should be considered as those conceptual models are being created. And those factors were age, gender, race, ethnicity, indicators of urbanicity, or rurality, poverty, social vulnerability, frailty, and disability. They had a lot to say about whether to adjust or not adjust for race. There were some members of the technical expert panel who felt that one should never adjust for race, and others who felt strongly that you could not make that statement. The reason for the grappling with that so much is that where there are biological aspects of race that could cause different outcomes, you would want to adjust. But where there are social or cultural reasons that race is imposing a difference on outcomes, you do not want to adjust for those. So they grappled with all of those things, Mark, and I think ultimately presented a set of guidance on how to manage this and how to move forward, including stratifying measures by those characteristics that I talked about, that I think was a good step forward.
And so that suggests that moving forward, at least a serious consideration should be incorporating those kinds of social factors into risk adjustment, race, ethnicity, and maybe a more accurate detail, and addressing some of the building on the recommendations that the paper made.
Well, I think I think that many of the panel members would say they wouldn't take the leap to saying you should be adjusting for those social risk factors. That you should be stratifying on the measure side, you should be stratifying, and that whether you should be adjusting really depends on the nature of the use. I'll share now, separate from what the panel said, I myself, as somebody who's just completed 6-year tour of duty on MedPAC, has spoken out on this and said, we can have our cake and eat it too, if we adjust on the financial side, not on the measure side.
Yeah.
That allows us to invest in health equity by either providing more upfront money to those who serve a disproportionately vulnerable population in terms of social risk, and or to give a greater reward, a multiplier on bonuses, if you will, for those who serve those populations. And that way you don't have to obscure measure performance by adjusting. You leave the measures as they are or show them stratified, but you adjust on the money side in order to acknowledge it could take something different to care for different populations. But when you invest in that way, that could allow you to achieve the same great outcomes. And let's not set a different standard based on social risk. So no easy answers, but that last set of statements is my own personal view on this.
Okay, thanks. And I do want to come back to some of the other work you've done on patient-reported outcomes and how we can move, given that's where the previous panel went, how we can move towards more reliance on patient-reported data for risk adjustment, and I know that's a priority for you for performance measurement as well. But first, let me go bring back in Erica. Thanks for all the effort on this, Erica. We had some discussion on the last panel about the limitations of clinical risk measures derived from the current HCC methodology, including, Rick saying he wasn't sure that this was even, that fundamentally this was a good foundation going forward. CareJourney has done a lot of work with electronic clinical data and a lot of work to support organizations trying to improve their clinical performance and their financial performance based on better clinical data systems. What are your thoughts about where we can go to address some of the data problems related to diagnoses where reliability, accuracy just seems challenged under the current systems? And maybe you can talk about a little bit about Rick's concern as well, that, well, we could move over to clinical data systems, registries and the like, but there might still be some of those same incentives to be more aggressive in the clinical coding, just like there was in the claims coding.
Yeah, thanks. I agree a lot with a lot of what Rick said about the system being broken. And I think I have a unique perspective coming at this from a software engineer, lawyer. Like, I haven't been baked in the system. And so as I approached it some number of years ago, and I was like, it's a weird situation we have going on here. And so I've been, just as I kick around different ideas and we talk about this electronic data and we look at like technologies outside of the healthcare system. Like right now, I can type into a chatbot and it understands me, it responds as though it's a human. And so we think about like patient-reported outcomes or how we get diagnoses from patients. And you can think about a system with like natural language processing that could listen in on a patient-doctor conversation and maybe extract what the patient themselves says their symptoms are and translate it that way to, this is next world situation. But I think you end up in the same place. You end up with being trained on how to elicit information out of your patient, how to coach your patient to say, I'm a lawyer, right? I can coach you to say what I want you to say on the stand. So, I'm an optimist, but I think that there will always be a situation where the system is gameable. Speaking to what Dana was just talking about and how we can incorporate other data aspects into this, I love the ideas of let's throw the system out and try to risk adjust based on where a person lives. There was a paper from Stanford that takes American community survey data, so census data, which is like at a 5-digit zip code level, and they did tie it to claims data. And they looked to see if the current risk adjustment algorithm could accurately predict costs if you add in some extra data, like where does a person live? Is it an area where English is spoken poorly, little broadband access, like things of that nature. And they also then tried the same process with machine learning. And what they found was that with the current algorithm, adding in the SDOH data didn't really actually make a much difference in the outcomes. But in the machine learning, when you add in the SDOH data, you do see a better predictive value for that segment of the population that we consider vulnerable. And so, one of the things we are working on is a whole bunch of health equity research, which isn't directly tied to risk adjustment, except that we are studying patient outcomes cut by a bunch of different data that we are sourcing, like from the census and tying to claims data. So, moving into, where we can go with risk scoring, I think you could draw on technologies that are not currently in healthcare to try and see if we can understand what a patient is actually saying. But we can also tie it to data that we trust and is objective, including like census data. And I would also say that CMMI is working on doing beneficiary reported data. So beneficiary reported race data collection and beneficiary reported SDOH factors, which are like the gold standard for researchers and for anybody trying to do this kind of work. So it's not necessarily beneficiary reported, like how do I feel today or what, good days measures, but it will definitely help us in tying this demographic data to risk scoring. Yeah.
Great. Well, great comments. And anyway, I think seems like a tremendous potential for ML and artificial intelligence to take data that we have and help use it more effectively, both for better patient care and potentially for better payment policies. One of the basic rules, though, is as you know better than anyone, is that the quality of the ML and the quality of these other techniques totally depends on the quality of the underlying data. And you've talked about how maybe, if reliability of data is a key here, and how do you get to reliable data that's most important for predictable risk and most important for aligning payments with the goals of better outcomes, accountability for outcomes, and total cost of care. Regional data certainly can contribute to that, though there are lots of variations within regions, and there are statistical issues that arise when you attribute trying to analyze individual level data on the one side and regional level data on the other. But certainly an important dimension that CMS is pursuing right now. We've talked about some individual reported data. We've talked about clinical data that might augment what you can get from individuals or regions, but since it seems like those data are inherently coming from the clinical care systems used for patients, we've got to pay attention to the issues that we have talked about throughout this webinar. How do you assure its accuracy, and are there efficient ways to audit or other steps that could be taken? But I do want to bring up the other category of data that's been raised, since Dana, I know you've done a lot of work on this too, which is other beneficiary reported data on functional status, on outcomes that matter. I mean, those are pretty important in terms of care that's patient-centered, not things that have been included extensively in most of our payment systems, including in Medicare, but you've taken some steps in your prior work to get there. And it seems like a key part of a CMS strategy going forward on the performance measurement and accountability side. But it's also linked into these determinations of risk and potentially risk adjustment. So maybe some comments about that, where we go from here in that direction, both to support better, more reliable, and hopefully more efficient risk adjustment systems, but also advancing the goal of improving performance. I mean, these payment systems should interact constructively towards that goal.
Yeah, I'm really pleased to hear you ask that question, Mark. And as you said, the issue of patient-reported information about health, and let's differentiate that from patient-reported information about their care experiences. Patient-reported health information, oftentimes called PROMs, are some of the very best predictors that we have of future utilization and therefore of cost. And also of health outcomes. And so on the topic that we're here to talk about today, the inclusion or the ability of CMS to include functional status information reported by patients could tremendously enhance the value of our risk adjustment models over what we have today. I saw this in some work I was involved with before going to Blue Cross, when I was in academia, while I was at Blue Cross, and then when I was at Haven, that when you have a combination of claims data, clinical data, and patient-reported data, there is no comparison of the strength of prediction of outcomes, whether those are cost, utilization, or other health outcomes, to the power of the functional status information. And there's all kinds of good reasons why that's the case. So we need those data for purposes of risk adjustment, but we also need those data for the purposes of getting to the delivery system that we want, which is producing health outcomes, and health outcomes that matter to patients, which is, do I feel better and am I functioning better? And, as I think your question alludes to, today, we still have a lot of structural and I would say business case barriers to the ongoing sustained use of patient-reported measurement in clinical care. And so interoperability solutions that are needed are part of what's going to solve that. But we also have to do, as CMS has signaled that they will, is start to include as a requirement in our performance measurement programs, the collection, use, and data sharing of patient-reported data so that we can ultimately get to performance-based measures that use that information, but also for purposes of enhancing care. Care is more meaningful and more likely to produce good outcomes for patients when there is standardized information in front of clinicians about how their patients are feeling and functioning.
Yeah, I mean, certainly information that clinicians would like to have, and the potential seems like it's there with the progress that we're making on interoperable standards. I know something that Care Journey and Anish Chopra and the whole team there is working on as well. But I look at that and then look at all the investment in the RAF scores and trying to get the risk adjustment payments up, and just seems like there's some better opportunities for alignment. This goes to, I think, a couple of the questions in the chat. Some of those are very specific, and thank you all for sending those in, and we'll try to get specific answers to you on those. But some of the questions are along the lines of, how do we get to a better system? And we've talked about some steps in that direction as we're in this phase of taking a step back and looking at where to move towards. Erica, let me go back to you and see if you've got any final thoughts to add based on the questions that have come in about how do we get from where we are now to where we'd like to be, the kinds of best combination of data that Dana was describing.
Yeah, I think that, CMS ran an AI challenge recently where they challenged groups to use AI, machine learning, to accurately predict mortality rates for Medicare beneficiaries and things like inpatient stays. And I think that's a really interesting idea that I would like to see aimed at risk adjustment. Like, let's see if we can have some innovation. And I think there's a lot of data out there that shows that our risk adjustment algorithm is just, it could be better using more recent technologies in machine learning. We can test it, train it on data sets that can incorporate a huge number of variables, including social determinants. And if the goal of risk adjustment is to accurately predict costs, we can see which variables matter, and we can use newer technologies than just a regression algorithm, which is what it is now, to create more accurate pricing information. And then with the tailwinds towards these electronic health records and the interoperability and speaking to each other, like, there's so much money and effort going into that. We should really capitalize on that and integrate that into our current risk scoring algorithms, just so that we, then quality measures are going to be based on the same underlying data that risk scores are based on. And I think we'll just start to see a lot more synergies, and it feels like we're wrestling, and we might be able to all row in the same direction at that point.
And Erica, kind of building on that, Hal Luft had a comment in the chat, building on a couple of other comments that go back to what we've been discussing, keep coming back to as well. Shouldn't you kind of normalize down the plans that seem to be more aggressive? But of course, the challenge is, some of that may be aggressiveness, some of it may be really going after and trying to engage and deliver better care for higher risk, higher cost beneficiaries. Hal's suggestion was along the lines of, okay, that penalize the ones essentially, or rebase the ones that are reporting on not so good data. But as we create opportunities for using these richer data, maybe that provides a mechanism for some additional upward adjustment, trying to transition to that kind of system that Erica was describing. So Dana, any final thoughts you'd like to add, either based on that or other things before we wrap up?
I think that's a really great insight. And, your comment a moment ago, Mark, also pointed to it, is that business case barrier that I was mentioning that really has stood in the way of there being a strong incentive for the adoption and use of patient-reported measures could be knocked down pretty quickly if patient-reported functional health information was part of the risk adjustment model. And that seems like a win-win, since we know it is a very potent and valuable predictor of cost, and that's what we're trying to do. And we'd get the side benefit of making care better and more patient-centered. That seems like a very optimistic note to end on to me.
Well, it is, I appreciate the optimism at the end. This certainly has been a challenging topic to discuss. It's complex. It's brought out strong opinions on both sides, but I really appreciate the effort by the two of you, by Rick and Rahul on the earlier panel to try to frame the bigger issues here and to lay out some feasible steps forward to making progress. And I also want to give a special thanks to everyone who commented. We were able to get to some of those comments and build them into the discussion. We'll try to respond to some of the more specific ones. But finally, I would like to emphasize that this is definitely not the last word on this topic. This is an area where we hope to continue to collaborate with all of those who participated with us today and shared their ideas and constructive thoughts about moving forward, as well as the rest of the community that I know cares very deeply about these issues. They matter a lot for the quality of patient care. They matter a lot for Medicare spending. And my takeaway from today is, while there are challenges in addressing these issues, Dana, I'll end with your same optimism that there are some good ideas for a path forward, that progress on the one hand around electronic data capture is making possible. On the second hand, that progress on how we might adjust some of the payment incentives in both Medicare Advantage and traditional Medicare's shared savings and ACO REACH programs to better accomplish these goals could lead to some, as Rick was saying, potentially broad-based support for how to improve these programs. So I want to thank all of you for being with us today. Also, a special thanks to the teams at Duke-Margolis, Frank McStay and Sar and colleagues, as well as Care Journey for some of the technical analysis to support all of this work. I hope all of you who join us today will stay in touch. We do and expect to see more work coming from us collaboratively to try to address these very important issues for Medicare and the well-being of our beneficiaries and our nation's major healthcare programs. Thank you all for joining us today, and we'll look forward to seeing you at future Duke-Margolis events.